Okay. If everybody can just take their seat so that we can start. Okay. Right. Good afternoon, everybody. We are finally in the graveyard session. And as you can see, there's a lot of deaths that happen. Before I introduce the speakers, we've got 4 today. I just quickly want to say something and then we'll get on with our business. So one thing I know, that is if you are either born to be a rural health practitioner or you get a dose of rural medicine and then you become addicted to it. And I think quite a few of us are in that boat and we are sitting here today. I'm Charles Dreyer, Medical Manager of Oudtshoorn in Kanaland Subdistrict. We have a population of about 130,000 people and we've got a team of 438 employees delivering the service in a district hospital of 123 beds, in a second one of about 30 beds. And then we have also 11 clinics and 7 mobiles, of which 4 of the mobiles is in the Ladysmith district. And now, as the session is going to be about how COVID has changed our ethical judgment, I thought that I would share some happenings with you on how COVID touched Oudtshoorn as a town. So the question that I want to pose is, how far will you go in trying to protect your town? When the news of COVID spread from China to the rest of the world, and everybody was shocked by the devastating news of the high death rate and the overwhelming of services, I knew as an infectious diseases clinician that nobody will be spared by COVID. You can either prepare or be caught off guard, as so many of us were. So what did we do? One thing we knew early on, COVID spread from person to person, by air and by touching. So while the disaster response was still taking shape, and you know that took quite a while, 4 things happened in the town of Oudtshoorn. Secretly, meetings were held with the business chamber, and also meetings were held with the executive mayor and the municipal manager. Now, why I mention these particular 2 things is that those 2 things would bring feed into Oudtshoorn. And this all happened before the disaster was declared a disaster. So the Congo Caves brings in quite a lot of people from across South Africa and from outside. And the Kunstefees brings about 250,000 to 400,000 people into the town. So we had to try and prevent those feet from coming to Oudtshoorn. Otherwise, we would have been the hotspot, I presume. And against the backdrop of the disaster not declared yet. So a joint operations committee was formed with the medical manager as point person, and the hospital was prepared in such a way that we could address the COVID that's still coming. So then COVID hit the shores of Natal. And I mean, we're all aware of that. And then it spread to Cape Town. First, and then to George, Mossel Bay and Knysna, all along the coast, and then finally over the mountains to Oudtshoorn. But the fortunate thing for us here in Oudtshoorn was, while the wave was forming and stuff, we were not even on the backside of the wave because people in high positions listened. So COVID has forever changed the rules of engagement. It has forever changed the way how we think of people with having a hunger of oxygen. It has changed the way we practice medicine. COVID has pushed the services to become more streamlined and more collaborative than ever. And I know the learnings will be remembered by this generation and carried forward to the next one into the future. Thank you. Our first speaker is Lungile Hobe. She's the chair of Rudasa and the medical manager at Miscellany Hospital, KwaZulu-Natal. She has a special interest in mentorship based on the mentorship she received during a training. She's a veteran rural doctor mentor. In 2018, she received the Discovery Foundation Rural Institutional Award to improve the quality of care at Miscellany. COVID-19 meant she had to put her Masters of Medicine studies on hold. Discovery has identified her as a young doctor to watch, and Lungile hopes
on what we've learned over the time that we were struggling with the COVID pandemic. So usually this session is more about the reflections over the conference. But this year, Herman was kind enough to sort of apply for an ethics point. So we needed then to stick to the theme of the ethics. So I'm gonna sort of have a slide on ethics, but I'm not sure that that's the route that I want to take. So here is it. But then COVID hit, and then we started isolating them against their will. We started going into their homes. So immediately, I remember our first suspected COVID vehicle and went to the house. Even though the patient was just a suspect, the whole community started identifying them as a COVID patient. And then, oh, it's that patient that brought COVID into our community. He was, of course, isolated in the hospital, but his family was there. So his family got ostracized because no one would want to go into a home with COVID. But then we continued the tracing. Did we even stop for a moment to think what we were doing by doing that? Did we even offer them options? Because initially when it all started, we didn't even offer an option. We suspected you to have COVID. We immediately isolated you. And then at that point, everyone was so scared of contracting COVID that the family had to come from home to bring you food, because otherwise no one else was coming into your room to serve you food. But then that basket of goodies was also being dropped at the door. And then the family being told, no, you can't go through. And then the results came back 8, maybe 14 days later, and the test was negative. And then we talk about non-maleficence. So it turns out that that guy was actually on break from work. He had come from town just to come and see his family. He needed to get back to work. This guy in isolation, he might have COVID. He's coming a taxi. He's coming from another town. This is probably COVID. This is probably our first case of COVID. Did we think about the well-being of his family that he had not seen maybe in the last 6 months, and he was just taking a break for a weekend from work? Did we practice non-maleficence in that situation? And then you think about beneficence, again, same issue. You think about justice. As I was preparing this, there is a new theme around justice that comes to light, the distributive justice. So there is this slide. So we all talk about equality. But then we're like, maybe we want to talk about equity. But then at the same time, we want to talk about justice. But do we ever really stop to think about what do we mean when we talk about justice? So I think personally, for me, as a reflection, COVID made me think about what is it that I do when I say I advocate for equity? Am I being fair? What is it that I advocate for when I say that I advocate for justice? Is it fair? There was a big question about who gets vaccinated first. There was a big question about who gets to nurse these patients. And then you start getting into the workplace of healthcare workers where suddenly employees have to divulge their medical conditions so that they can be considered to not work in the COVID wards. Is that justice? I don't know. So these are just some of the examples when we know we got to learn this much later on in the pandemic that maybe ventilation was actually not contributing much to the survival of our patients. Do you still encourage your doctors to ventilate patients when you know that the risk to them is going to be much greater than that to the patient, or actually even not improve any outcomes for the patient? We talk about comfort care. How do you palliate a patient in isolation? Because when we talk about palliation, we always want to talk about improving the quality of life, but we won't even allow the family to come in and be offered at least PPE just to hold the hand of their loved one while they're dying. We stopped all spiritual care in our facilities. Pastors were not allowed to come in because we don't have enough PPE. But if I had to ask any one of you here, how much PPE do you have left over from all the COVID waves? Do you think it was justified not to let any pastoral care into the isolation wards? Should we have classified them as healthcare workers? Because we often say wholeness is mind, body, and soul. But I think we forgot about the spirituality or the soul part in this. Was evidence actually even in line with our practice at that point? Were we applying the ethics at all to our practice? Were we even stopping to think about what were the implications of what we were doing, or we were all just driven by our own vulnerability and fear? Oh, sorry, I've gone the other way. I've spoken a little bit about justice. In our area, we started having patients that had medical aids opting not to go to private. And now it meant that both public patient or state or uninsured populations were having to fight over the limited resources of beds and COVID tests that we had. And even just the human resources. Was there justice in that? Then we had to repurpose. I love this phrase, repurposing of beds. It often came as an order from above, but then it meant that there was massive injustices to your patient who needed diabetic control and needed an inpatient bed. Our admission capacity was reduced. Our hospital was reduced from being 185 to 152 bed. That's a big cut in beds. Some areas actually needed to end up mixing medical conditions just to get them a bed in hospital. I've already spoken about the risk assessments and reallocation. Autonomy versus utilitarianism. I think, I just want to challenge each and every one of you just to reflect on what we did. And of course, I'm not an expert in ethics, and I'm probably not the best person to stand here and comment on this. But since our theme for this year has been learning, adapting, and thriving, I strongly believe, and what I have learned from the COVID pandemic is that experience is seasonal. I think Victor did say here this morning that he is pre-HIV. I'm pre-COVID. And I think the best tool that we have within us is to learn, adapt, and thrive. And we need to keep thinking, are we being fair to our patients? Are we being just to our patients? Not just to our patients, but to ourselves as well, to our communities. Because the patient that you're seeing at your door, they're not living in a silo. They're actually part of a community. As we were talking about the ethics around CTOPs this afternoon, I actually reflected on an era that we might be going into. How would you feel when a transgender female comes into your consulting room requesting a TOP? In my head, I'm thinking, maybe you wanted to be trans just because you wanted to have children. But is that true? Are we open enough to learning and adapting to try and understand the context of that particular patient and their community and their needs? There's always going to be something new in our practice. Are we open enough to learn, adapt, and thrive? I am no expert. Thank you very much.
Thank you very much, Lungile. There's time for one question. One question. Anybody?
I have one question. What is the reflecting back? You know, how isolated healthcare workers were and how subject you were to the decisions of policymakers who didn't have to deal with what you dealt with on a day-to-day basis. Do you think it's time that organizations like Rudasa become more politically active in talking about the issues of rural health and rural health communities who rely on our services? Thank you.
Russell, I think our brains think alike because you've just covered an aspect of the presentation that I didn't say, an aspect that requests for collaboration. I think we all have spaces to occupy within our communities, be it academic, be it organizational spaces, or even communities. I think we try to create that with Rudasa, with the daily digest and sharing best practices. But I think we would have provided a better platform, Russell, in maybe even having sessions online or otherwise. Thank you.
Thank you very much, Lungi. Our next speaker is Marika Besaidenhout. Marika is a physiotherapist who spent 20 years at the rural coalface. She's currently the manager of a 21-strong multidisciplinary rehabilitation team, which works closely with local disability organizations and NPOs to provide comprehensive rehabilitation and disability services within the Manguzi Health Catchment Area. She has a postgraduate diploma in health economics, as well as a strong public health background. We're not advocating or finding ever more innovative ways to sustain services. She's probably full of grease repairing wheelchairs under a tree somewhere.
Hello again. I feel like I've been on the podium a little bit too much this conference. So without ado, South Africa remains one of the most unequal societies in the world, with inequalities including health access and outcomes drawn along racial, geographic, and socioeconomic lines. People with disabilities remain some of the most vulnerable and marginalized in the society, and recent household and census data indicate they still remain poorer, with less access to government services, including health, social services, and education than their non-disabled counterparts. A review of disability and rehab data in the 2020 South African Health Review showed gross discrepancies in access to assistive devices across provinces, with unacceptably low coverage rates overall. South Africa ratified the UN Convention on the Rights of People with Disabilities in 2007, requiring routine reporting on progress made. An exercise made extremely challenging through the lack of disability data across sectors and the low quality of data within each sector, including the health sector. A recent initiative by the Department of Social Development, Stats SA, and the World Bank attempted to engage government departments around the need for the harmonization of the definition of disability and inclusion of disability in data in order to improve monitoring and build accountability around service delivery for this vulnerable group. However, the response has been sadly a little bit lackluster. This lack of data limits civil society's ability to hold the government accountable. It makes it impossible to apply vertical equity for marginal groups when planning, budgeting for, implementing, or monitoring government services. Many of the presentations by therapists at this conference have really highlighted the general lack of rehab service data, and a few have engaged in innovative approaches to generate data which is critical for grassroots program management as much as it is for advocacy and policy. With seemingly essential services such as SASSA and home immediately reduced staff and services. Even community health workers, arguably the backbone of the response, as the interface between health and community, were pulled into clinics to assist with screening rather than performing household needs assessments. Despite people with disabilities participating in the government's COVID Crisis Committee and the Presidential Working Group on Disability providing recommendations, key policy responses guiding healthcare workers, including the National Infection Prevention and Control Strategic Framework, the COVID-19 Quick Reference Guide for Clinical Healthcare Workers, and the allocation of scarce resources during COVID-19 public health emergency in South Africa, failed to directly speak to disability. In fact, we went as far as utilizing the clinical frailty score, directly limiting people with disabilities access to emergency healthcare until it was challenged and amended. Even little attention until later in the pandemic. The organizational culture within the Department of Health, a historically siloed approach to service planning and delivery, and a curative focus in healthcare consistently failed to recognize or include disability and rehab in essential health policy and planning initiatives, something which I am going to maintain faith is going to change. However, we cannot continue to lay blame solely at the feet of other professions. Leadership and communication from national and provincial departments of health, Health's Disability and Rehab Directorate was highly variable or entirely silent, leaving therapists and managers on the ground to make their own decisions regarding service delivery and reforms. Decades of underinvestment in disability and rehab services and a lack of recognized staffing establishments meant that services prior to the pandemic were already highly fragmented, poorly organized, largely centralized to hospitals, and at best, clinics, and of variable quality. Few departments have a full multidisciplinary rehab team. Few provide outreach services beyond clinic visits, and few have sufficient or appropriate databases or systems in place to actively monitor service delivery and program performance for high-risk groups. HR data, which is now available thanks to Quinette Lowe and Tadi Conradi through their Rehab Capacity Project research. May there be more. Many rehab departments simply shut shop, reduced staffing by 50%, or limited services to inpatient activities only. Few departments, even if they had wanted to, had the staff, vehicles, or the systems to identify and prioritize households at risk, rapidly scale, and monitor the provision of consumables and medication required by many clients with disabilities. They could not rapidly decentralize services to household level. Supply chains for assisted devices were, and still are, completely disrupted. And together with the cancellation of outreach services, an already poor service and assisted device coverage rate went from bad to worse. South Africa's public sector was caught napping, with broken and incompatible systems, little community footprint, and a backlog in service delivery that should have been addressed systematically in the last 30 years. Decisions around a hard lockdown failed to appreciate the lack of preparedness by government services on the ground to roll out relief measures for the poorest. It turned a blind eye to the complete lack of intersectoral collaboration. Unable to address the social determinants of health during a pandemic, it threw an army at the problem instead. Thank goodness for civil society and for NGOs. So whilst we still have no real-time data on rehab staffing levels, we must be grateful for the COVID relief contract therapists that were placed in institutions at all levels of the system. Where used judiciously, they allowed permanent therapists to concentrate on building better systems and expanding outreach services. We pray that institutions will be given the funding to absorb them. Urgent attention is required in rehab HR mapping, establishing staffing establishments reflective of the need for sufficient, appropriate, and appropriately skilled rehab staff at primary healthcare level, as well as employment of end users in service delivery itself. Post-moratoriums and the random prioritization of medical doctors and nurses over other professional categories in absence of any explicit or rational HR monitoring strategy must stop. Where there has previously been little or no attempt at inclusive engagement in guiding emergency responses, we welcome the inclusion of people with disabilities on the National Crisis Committee. We only hope not only that recommendations of mainstreaming disability across all sectors and programs and increasing end-user engagement is taken and implemented, but that the voices of people with disabilities from rural and underserved areas are heard, and not just a privileged few. To achieve this, the knowledge and attitudes of budget holders and decision makers towards disability must change. Organizational culture and channels of communication within government departments must change. And a sustained approach towards building capacity and inclusivity within municipal forums and health boards and committees must occur. We sincerely hope that the disability data harmonization effort initiated by DSD and Stats SA is supported in earnest by other government departments, and for improvement in the funding of Stats SA. Efforts at improving accountability, as well as the use of data, including the ability to stratify for disability at local level for policy, planning, monitoring purposes, is urgently needed. We consistently try to make the person fit the service rather than designing the service around the person. This approach largely ignores the multiple barriers faced by vulnerable groups in accessing and remaining in care and deflects attention from the need for intersectoral collaboration in addressing the problems at hand and robust health systems. Whilst a certain level of responsibility for seeking care must remain with the patient, in ignoring the direct impact that current systems and services have in driving and perpetuating inequalities will never improve health outcomes. Current health systems are largely passive, relying on the patient to initiate contact with the system. Data is often inadequate to derive a denominator or monitor coverage rates for particular vulnerable populations. COVID has shown us the sheer scale of unmet need in communities. Yet, it is all too easy to simply slip back into practices which drive and perpetuate inequality as health utilization rates return to pre-COVID levels and budgets and resources are further reduced. And without data, no one will be the wiser. Thank you.
Thank you, Marika. I have question for time for one question for Marika, just one. Because of the long lunch, we run a bit short of time. Anybody got a question? Where's the...
Marika, I'm interested in the issue of data around disability in districts. And, you know, the COCTA have a whole data program that's going on, trying to get real life information about crises, you know, floods, events, episodes, things that go wrong in community, right from the traditional authority level up through to the Premier's office. I wonder whether you have got any data involvement for disability in that program, because it seems to me that you have a potential to make that, and it could be useful to, that's KZN, I'm obviously not whole national, but.
Thank you. Don't want to answer. Okay. Thank you. It looks like, Victor, you made a statement more than a question. Yes. Yeah. Okay, thank you, Marika. Our next speaker is Sabang Siperua. He's a clinical associate practicing at ODI District Hospital since 2017. He's a humble, hardworking person and passionate about health in South Africa. He's founder of the South African Union of Clinical Associates and executive member of PACASA.
Colleagues, I know that we are full from the food. So you must understand. So COVID-19. So I'll be sharing with you my experiences. They taught me that do not judge. I don't judge. But one thing I'll tell all of you is that history will judge us. So you need to know that. So we all know principles of ethics, but I was touched by this one of harm, do no harm during COVID. So I will be sharing my personal experience, and then you have a task of applying those principles. So I will start by sharing a background of my hospital, where the experience is coming from. So all of us know Tshwane, the city of Tshwane. Oh, let me check the time, sorry. Yeah, all of you know the city of Tshwane. So my hospital is under the city of Tshwane. Our referral hospital, it's Dr. George Mokari. All of you must know it. So it's George Mokari, it's Odi District Hospital. That's where I work. And the other district hospital, it's in Hammanskraal, at the border of Limpopo and Pretoria. And we have a lot of clinics, and it's a mess. So the people of Western Cape, they must admit that they are privileged. Their health system is working for them. And they must be grateful for that, and they must at least be agents of pushing positivity. You know, tell them, no, change the system in Gauteng, change the system in Limpopo. It's all our responsibility, because if we don't do that, history will judge us. You know, how do you eat when your colleague is not eating? Anyway, It's fine. So we have a lot of clinics, and trust me, it's a mess there. It's a mess. So I will start by where I used to work. I worked in triage. During COVID, my manager came to me, was like, Tabang, please go and work at triage. I'm like, how? You want me to chase people away? Yeah, it's a fact. If you work in triage, you must tell them, go to the clinic. It's a fact, and you must stabilize. So I said to him, but I don't have the resources of triage. There's COVID, there's non-COVID, our normal patients that we had. You must remember that doctors and everyone was forced to write prescriptions of 6 months. What is that? Were we not causing harm? We were not monitoring the drugs. We were just writing. Can any of you say, I didn't do it? Say it if you are confident. You understand? So you have to understand where is this going. You understand? We didn't have the resources. Our triage room, it's just a normal room with chairs and a table, BP cuffs, and there's also a window. So I had to tell them, let's have a window for the COVID suspects, and here it will be our normal patients that will come on a daily basis. So my biggest challenge was the clinics. They must not say that they didn't have the resources or the knowledge or preparedness. All of us were like that. But as a person, it's your responsibility to empower yourself. So I used to watch YouTube videos from Charlotte Makheke. Those were the first people to respond by YouTube. They were teaching us how to do the swabs, how to do it properly, how to use the intube box. So I read those, I went through those videos, everything. So it's your responsibility that you know what you know and you know what you don't know. So it was their responsibility. So they will send 6 patients. It's a clinic. Someone was employed to work. You know, they were supposed to educate the patients, do the risk assessment, or no, you are not a contact. They will send 6 patients. Not just, you know, one group. They will send 8 to 10 groups of 6 people. So judge me if you want to. I will look at them and do vitals on them, then say, go back to the clinic. They must test you. Because every clinic must have a family physician. If they didn't have one, it's not our responsibility. You understand? So people were like, no, you will get into trouble. I'm like, it's fine. It's fine. I'll dance to the music. So that's challenge number 1. Our clinics were referring everything. After a few weeks of turning patients away, my boss called me. Hey, you are overdoing these things. You are not the boss here. I'm like, chief, what's happening? You said I should. Yeah, you understand? So it's fine. We will see them. Mind you, the president said we must test everyone who comes to the hospital. We had to test 50 people who did not need the test. You test them, that's a problem, number 1, because it was causing a bad luck. You must understand that there were patients that died, and on their BI, we will write COVID suspect. They die 5 days after being in the hospital, some 7 days, but still no PCR results. So be the judge. What were we supposed to do? Were we supposed to test those ones who didn't need the test at the hospital, or were we supposed to chase them away, because now it even affects the funeral arrangements. So COVID was deeper than it looked, especially in the public health care of other provinces except Western Cape. It's a fact. So another thing besides the clinics, as I said to you, there was no specific triage room. One of the days I was there in my triage, there was a container, there's a COVID container that patients will sit there. The ones with referral letters, the ones that needed the test. But what I didn't like is that clinicians didn't, think of other diseases. Oh man. Anyway, what I would like to say, I won't end it now, but it's quite important that there were positives that came out of COVID. It showed that we are a great nation, our universities are good, and they were able to come up with solutions. But anyway, I had a lot of things that I had to share with you that I think will have changed your lives, and you are gonna be agents of change. Anyway, it's fine.
It's clear that Tabang had still a lot of things to say. So I allow 2 questions for him. Because he didn't make use of his other 2 minutes.
So I'm not only opening the question to Tabang, but to everyone. Judging from the presentation, it seems like we all knew what ethical things we needed to do. However, we were getting directives from above, and it's like we knew that it's not right, but then we still listened. The whole to cause it, but we're causing it anyway. So I'm just trying to find out, should we find ourselves in that situation again? What do we do? Do we say, no, we're not going to listen to you, we've studied, we know what we're talking about, or just roll over? Thank you.
I'm not sure if they are willing to answer you, but my answer will be prepare. That's the only answer. Prepare. You understand? Prepare the health system. Then it won't have crisis. I personally don't think the crisis was as bad as it was in Western Cape. Let's be honest. They have clinics. Their clinics have doctors. They were doing the tests and they were referring patients that needed referrals. So let's prepare the health system and then we will win. Another question?
I can speak. I would like to respond to that open question about what should be done.
The guys online.
Yeah, thank you. I think from the conversations I've had with many people about approaches to COVID, that it would be good for Rudasa to come up with a statement about who should come first and how should healthcare workers respond in such a difficult situation where there are orders from above that at the context where we work does not necessarily make sense. I think that would be good to come from this conference, because certainly amongst many, many moving and important discussions and conversations, this is one that I've stumbled across over and over again. I don't have easy answers either. I was in a very different system at a tertiary hospital where we did get very good referrals. And in that, we had good triaging and that. But I think it's really important that we do think about the next pandemic, because there will be a next pandemic. And I think that preparedness is also in how should it be addressed by healthcare workers. I would think that would be a good idea. And thanks for your presentation. I think it does all make us think again that these things sound quite easy, and they're actually not very easy if we don't respond and don't think about it deeply.
Thank you, Sabang. It's clear that when we are going to be confronted by some things that we don't know about, that we should very early make sure that we understand what is coming our way, even if we don't know everything at that particular stage, and then you prepare beforehand while you still not know what is going to come. Thanks, Samad. Our last speaker is Tabi Singh Sabisi. She's a professional nurse and is the chairperson of RUNERSA. After serving as the Northwest Provincial Representative in 2016 to 2018, working towards harnessing rural nursing leadership in advocacy, she also delivered the keynote address titled Working with the Traditional Healers for Equity in Healthcare at the 2021 Rural Health Conference held in Limpopo. Propelling her to form part of the team developing the rural health curriculum at Stellenbosch University. She participates in social justice courses such as Food Justice Campaign under a coalition with members of civil society such as Sasquatch, Black Sash, and Children's Resource Center, among others. As RUNERSA chairperson, she is also a board member of the Rural Health Advocacy Project.
Hello again. Allow me to represent the nurses. I will be sharing some of my personal experiences with regard to the time of the pandemic and the measures that we put in place in order to support healthcare workers. But in essence, we know that the pandemic had a huge economic and social disruption, and it also placed a great strain on the health system that was already strained. Countries like South Africa were exposed for the already inadequate governance, resource allocation, and financing of medical supplies. So the nurses' frontline role increased their risk of infection, especially where PPE was scarce. I think we all know the story with PPE and what happened in Gauteng, the MEC. The nurses did raise their dissatisfaction over the lack of PPE, and in most cases, employers did not meet the standards for the provision of PPE as prescribed by the WHO. Although the nurses' lives were endangered, nursing ethics still bound them to put patients first and prohibited them to engage in strike actions when working environments were unsafe. I'll just continue. So let's look at ethics and COVID-19. What the International Code of Ethics is saying. It states that within nursing, there's a respect for human rights, including cultural rights, the right to life and choice, to dignity, and to be treated with respect. And this is for patients. But this pandemic have caused moral distress and unexpectedly challenged the ethical in many settings. This is just to show you the nurses' pledge of service and how it binds them to the ethics, and it's underpinned by the values that you see on the right, and clearly and underline that devotion that the nurse has to stay devoted regardless of the situation at hand, under which the nurses are working. And one of the roles is to advocate for the rights of healthcare users. But all of that pinned by the biomedical ethical principles, which is autonomy, beneficence, non-maleficence, and justice. But now, what was the problem within this sphere? There was poor planning. To continue to provide healthcare for other conditions. Workspace, people were closely monitored until they are healed and come back, and there was no mental health support. You just had to, okay, go home, isolate, get your treatment, come back into service. So despite their professional obligations, nurses are also human and such experience psychosocial impacts from their work. They face multiple ethical, social, and legal dilemmas where they had to prioritize the lives of the patients as per the scope of practice and their own. Some of the voices from the field, I'll just read to you 2 excerpts there. It was very hard, and the experience of nurses and doctors on the ground. For example, one doctor shedding tears as they informed the staff about the difficult decisions that will be made in the coming weeks about who to resuscitate because they don't have enough ventilators. That was a crisis for everyone. So patients needed to be, I don't know what scorecard they use to prioritize who gets life support and who doesn't. And also there was this coming around the corner to find that one of my patients has passed alone while I and everyone else was too busy to be by her side, living with the guilt that I couldn't honor her and her family by being beside her. I did not sign up for this. This is a catastrophe. This is from a nurse in the United States. Remember that our role as nurses is to render holistic care for the patient all the way until they die. We render palliative care as well. But the pandemic didn't grant us the opportunity to do so. People were dying alone. So with all that said, still, we had to be resilient. So what worked? What was beautiful, for the first time, we saw the international stage opening for nurses to, share experiences and learn from one another and adopt strategies that actually worked. So there was a continued webinars, everywhere, and this capacitated nurses to actually cope even. So there was some mental health support there in that space. We also saw innovative models emerge during like any pandemic, like in telehealth. For example, in my workspace where we used to have the adolescent and youth HIV care, a group-based approach, we now went virtual. We tested the method and we published it with Team Pata. It's there in their resource hub if you would like to test it in your space. But we also face challenges with things like using WhatsApp for pre-reminders for the clinic appointments because there was, lack of access to technology and internet. And this is in Tshwane. So can you imagine someone sitting in Kandla, not even having a smartphone or access to data? How will they participate? Then this led to high patient loss to follow up to care. And what was said is that I had established over 90 youth care clubs across 24 youth-friendly facilities in Tshwane, and the numbers dwindled. I think we had to cut down and, adapt. And we made submissions to National Department of Health on how we can adapt the whole strategy of youth care clubs, and we have contributed to the writing of the new AYFS Implementers Guide that has that virtual youth care club as one of the models that can be used. But we lost children, adolescents and youth because of lack of access to resources. So 2 minutes. Okay, home delivery of medication also relied heavily on the DSP support. District didn't really support that, but nurses had to work. We saw CCMDD guidelines being adapted to suit the context. We also saw the professional and public support raising the nurses' morale during the pandemic. I think after it was announced that we are going into lockdown for the first time in a long time, I put on my epaulets and I went out. And as I went, the security at the gate, he did this with much respect. The streets were quiet. I felt very important and honored to be part of this, huge thing that is happening. And the spotlight was on us as nurses and other medical or healthcare workers. But with all that said, we innovated, we did stuff. The fact remains that there are ethical problems and they need to be addressed. And they are complex because there's rural-urban disparities and others. So they require multidisciplinary thinking and policies and strategies to guide future practice. I think Commander said there, Guti, we need to prepare. We cannot sit and wait for crisis and then we are reactive. We need to work ahead, and frameworks that guide the ethics of nurses need to change. We need to move with the times. Now things are changing very fast. We need to learn from pandemic outbreaks and then prepare better, improve the understanding of the ethically justified expectations regarding the public. The employers and the co-workers can reasonably expect from nurses their role and responsibilities during such. And also remember that nurses are also human beings. They need to be taken well care of. So I think what came through mostly among nurses was the need for debriefing and mental health support. Thank you.
Thank you, Tapijeng. Any questions there at the back?
Just gonna take advantage because I'm closer. The issue of mental exhaustion. It was not just peculiar to nurses. I think all the frontline workers experienced that. How do you think would be an ideal way of approaching that? Because I'll tell you that in most institutions, immediately after COVID, the degree of absenteeism was ridiculous, and not necessarily because people were sick, but because people were exhausted psychologically. So is there a way that you think we could probably work around that so we don't end up with the same situation in doing what Commander said about preparing?
Prepare. Indeed. Can I answer? We should stay prepared, and we have programs in workspaces. We were being referred to. Remember, you've got discovery, they have this and that. It's not easy. Sometimes you need someone that works with you to give you that kind of support, to give you that hug, to listen to your story and your frustrations. And what we saw, the pandemic caught us already frustrated with the challenges we're facing. So we need to stay ready. We need to have learned from this pandemic and do better in terms of mental health support. And I think if doctors and nurses, all frontline healthcare workers can come together and not just workers, colleagues on an equal scale only when there is a pandemic, but on an ongoing basis, we need to stick together. Thank you.
Thank you very much, Tabiseng. I just want to say one last thing. The fact that families were put in a situation where they were not able to see their dying loved ones, that was a very difficult thing. So yeah, here in Oudtshoorn, we try not to always keep by the rules. So we broke that rule very quickly and early in the pandemic and allowed people to see their family.
Okay. I am still